I welcome all of you to this surgical management of pediatric cataract. It will be video based learning, and with me I have my faculty, Dr. Parul Chawla Gupta. She is associate professor at PGI MER Chandigarh. Show the next slide. And she is exclusively working in the field of pediatric. And we have Dr. Savleen Kaur. She is exclusively working in pediatric ophthalmology and doing pediatric cataract and also strabismus. Dr. Jaspreet Sukhija, he is professor, but actually due to he has undergone surgery only recently in emergency, so his talk will be delivered by Dr. Savleen Kaur. And I am Dr. Jagat Ram. I am now I am retired from PGI after doing 42 years of service to PGI, and I will also be topics we will tell of each. Regarding the introduction of this course, there is a tremendous change. There is tremendous change for the last 42 years which I have witnessed in the field of pediatric cataract surgery, because while I joined PGI 42 years 4 months back, that point of time only people were doing needling and aspiration, and then came the technique of extracapsular cataract surgery and IOL implantation, and then this is followed by phaco aspiration and IOL implantation. There is a, even now at present, people are doing pemato assisted laser cataract surgery. We will discuss in detail, but particularly in the surgical technique and IOL implantation, there is tremendous change, particularly in the IOL implantation. 42 years back, I think very few people or nobody was implanting IOL, but as the time passed, indication came that okay, up to 2 years or more we can implant IOL, because due to growing eye, there are a lot of issues of concern, such as IOL power calculation and issues. They will be discussed in detail. And then at present, more and more number of people, they are implanting IOL, and the age for implantation has gone down. Even the child which I operated about 25 years back, that child is now 25 years, and he has done MBBS, and his vision is excellent. That point of time, 25 years back, even that point of time, I did primary posterior capsulotomy and anterior vitrectomy. So there is tremendous change in the surgical technique as well as IOL implantation indications. So first of all, I will request Dr. Parul Chawla Gupta to speak on the basic steps of pediatric cataract surgery for the beginners.
A very good afternoon to all. Today we will be discussing the basic steps of pediatric cataract surgery for a novice pediatric surgeon. So congenital cataract has a worldwide prevalence of around 4.24 per 10,000 people, with the largest prevalence found in Asia. It is one of the most important treatable causes of childhood blindness. So what should be the timing of cataract surgery? To prevent stimulus deprivation amblyopia, dense, visually significant bilateral congenital cataracts, the surgery should be done around 6 to 8 weeks of age. And for unilateral visually significant cataracts, it should be done around 4 to 6 weeks of age. In fact, now they recommend around 6 weeks of age because the vision before that is mediated subcortically. So it won't make a difference whether you operate at 4 weeks or 6 weeks. In fact, the younger the age that you operate, more will be the chances of glaucoma. So increased rates of post-operative glaucoma in the first 4 weeks of life is seen in literature. So that is why we prefer to operate after 4 weeks, that is around 6 weeks, especially in unilateral cataracts, and bilateral can be delayed even later. So I'll just give a brief account of biometry. It will be discussed in the future presentations also. So axial length can be measured using an immersion or contact A scan or using B scan ultrasonography. And while using the contact A scan values, the value with the maximum anterior chamber depth should be chosen to offset the inadvertent indentation of the cornea with the A scan probe. Keratometry values can be obtained using an autokeratometer. It can be handheld. Reading should be preferably taken without using the eye speculum and thereby avoiding the compression of the globe. Optical biometry with IOL master or lens star can be carried out in older cooperative children. So intraocular lens power in children should aim for moderate hyperopia post-operatively to compensate for the myopic shift which is expected in children due to axial elongation of the globe. An IOL can be implanted in eyes with an axial length of more than 17 mm and corneal diameter of more than 10 mm. SRKT and Holiday 2 formula give the best post-operative outcomes in pediatric eyes with axial length less than 20 mm. And in the IATS study, that is the infant aphakia treatment study, Vanderveen et al. Have shown that SRKT and Holiday 1 have the least prediction error in children. In a study by Dahan et al., we can also do 20% undercorrection in children less than 2 years and 10% in children between 2 to 8 years. In fact, another study by Prost has suggested 20% undercorrection in less than 2 years, 15% in 2 to 3 years, and more than 4 years, 10% correction, undercorrection. So there was a recent study by Chang et al. In 2020 which compared 8 formulas in less than 8-year-old children, and SRKT and was used were the best in axial length less than 21 and age less than 2 years. And the Barrett's and the Hagees were best for age group more than 2 years and axial length more than 21. So this is one video which I'll be showing you. Can you increase the sound? So after making the side ports, we inject the trypan blue dye. To discuss in detail, the incision, it can be a superior clear corneal triplanar incision of 2.2 mm or 2.8 mm, which is preferred in children, as the wound is protected by the upper eyelid from trauma. Scleral incisions 2 mm from the limbus with conjunctival peritomy are rarely used these days unless we are using a rigid PMMA lens. Smaller, tighter fitting incisions help in better maintenance, AC maintenance, and stability of the anterior chamber. They minimize the times in and out of the eye. And 2 uniplanar 1 mm incisions approximately 180 degrees apart give better maneuverability. This is for the side ports. So 2.2, 2.8 for the main port and 1 mm for the side ports. So to address smaller pupils in children, small pupils less than 4 mm in diameter lead to a higher rate of complications. Posterior synechiae can be due to uveitic cataracts, traumatic cataracts, persistent fetal vasculature, and pupillary fibrosis. So we dilate the children pre-op with tropicamide 0.8% and cyclopentolate 0.5%. And 1 in 1 lakh preservative-free adrenaline can also be used intra-op, and nowadays we are using phenocaine, which is a combination of tropicamide and lignocaine in order to dilate the pupils of children intra-op. So why anterior capsulorhexis is difficult in children? So children have a capsule which is thinner and elastic. It is convex shaped. It can tear easily and easily run peripherally. and the AC is shallow and the eye is also shallow. IOP is lower because there is less rigid sclera and easily collapsible. And poor red reflex might be there due to the opacities. So anterior capsulorhexis can be done by various techniques. We can use a curvilinear capsulotomy. We can do it with a vitrector, that is a vitrectomy cutter, that is known as vitrectorhexis. We can use a 2-incision push-pull technique in which we give 2 opposite incisions on the capsulorhexis and then extend them circumferentially. We can also use the 4-incision technique in which we give 4 incisions in each of the 4 quadrants with the cystitome and then join them all together. We can also use a femtosecond laser assisted capsulotomy technique, and we can also use a plasma blade or a fugo blade for capsulotomy, or intraocular diathermy, and precision pulse capsulotomy or the Zepto. So what we use most commonly is the curvilinear capsulotomy, the vitrectorhexis in case of fibrotic pupils, and we also use femtosecond laser assisted cataract surgery, which Professor Jagat Ram has done in a series of patients. So initially we stain with the trypan blue dye, which is 0.06%, and this makes the capsule rigid and stiff. Anterior continuous curvilinear capsulorhexis is done with a cystitome and followed up with a utrata forceps. It should be smaller than the IOL optic diameter. So usually the IOL optic diameter is around 6 mm, so we make it around 5 mm to prevent shallow AC and post-operative pupillary capture. So anterior capsulorhexis is around 5 to 5.5 mm and posterior around 4 mm. And vitrectorhexis is very quick and simple, done with a vitrectomy cutter and used in fibrotic capsules. So we prefer to use a cohesive viscoelastic, that is a high molecular weight ophthalmic viscosurgical device. It flattens the anterior capsule and keeps the anterior capsule taut. And it also counters the effect of low scleral rigidity and vitreous upthrust. So this is a picture of the cohesive viscoelastic which stays there and maintains shape, and this is a dispersive viscoelastic which doesn't maintain shape, it just coats the endothelium. So we prefer a cohesive viscoelastic in children because the capsulorhexis tends to go to the periphery. So what are the tips for anterior capsulorhexis? We need to pull the capsulorhexis margin centrally. That is, we hold close to the margin where it is tearing, and with the utrata forceps we try to pull it centrally and at around an angle of 45 to 90 degrees. We use a cohesive viscoelastic as discussed, and we take frequent bites of the anterior capsule. We keep on catching hold of the capsule where it is being torn. Multi-quadrant hydrodissection is done using a cannula mounted on a 2 cc disposable syringe filled with a BSS. At least 3-quadrant hydrodissection should be done to facilitate easy lens matter aspiration. And coaxial or bimanual irrigation aspiration handpieces can be used. We start from the periphery and swipe clean all the cortical matter. It is essential to polish the capsule also because the remnant anterior lens epithelial cells can proliferate and migrate and lead to different forms of posterior capsular opacification. IOL implantation. The anterior chamber is filled with high viscosity viscoelastic. Push the leading haptic, that is the first entering haptic, underneath the anterior capsule and then push the trailing haptic into the bag using a Sinskey hook. Single piece hydrophobic acrylic IOLs are preferred for in the bag placement. This leads to less posterior capsular opacification and pigmentary deposits on the IOL because the haptics will be placed in the bag and they will not continuously rub against the iris. 3-piece IOL, but sometimes 3-piece IOL can also lead to inadvertent posterior capsular rupture, so we need to be careful. Monofocal IOL is preferred in children. However, multifocal IOL can be implanted in children more than 5 years of age with bilateral cataracts. So what should be the lens material? Silicone, if we use a silicone material lens, then it can lead to silicone oil deposits if in case there is a posterior segment surgery. It can lead to calcification with asteroid hyalosis and opacification with the air fluid exchange also. So all these complications take place during the retina surgery. So we should avoid a silicone IOL. Hydrophilic acrylic IOLs, they lead to late opacification and calcifications. They also absorb the dyes. That is, you might see a blue lens in the eye. So you might wonder what it is. So that probably is due to the hydrophilic acrylic material which has absorbed the trypan blue dye and given it a blue color. They also sometimes absorb the canacot or the triamcinolone deposits. The hydrophobic acrylic are the best materials to use. They are less likely to opacify. PMMA, they are not foldable, so we need to give a large incision. but they are stable in the sulcus, so they can be considered in case of any complications. Peripheral iridectomy is a must in patients with aphakia or in patients with uveitic cataract or traumatic cataracts, and it can be done with a vitrector. And if the site bleeds, you can just put intracameral air, or you can put adrenaline or even viscoelastic tamponade, and then wash away the viscoelastic later on once the bleeding has stopped. So a primary posterior capsulotomy and anterior vitrectomy is very essential because PCO is the most frequent complication occurring in such children. Considerable risk of visual access obscuration and amblyopia in the children occurs in patients who haven't undergone this posterior capsulotomy and anterior vitrectomy. So it is, the risk of PCO is 100% with an intact capsule. So we use the cut IA mode, that is cut irrigation aspiration mode of the cutter, and we cut the capsule. And this is done in patients less than 8 years of age, or mentally retarded children who are even more than 8 years of age, or those having nystagmus, because they won't be able to sit on the yak cap slit lamp machine. So posterior capsulorhexis should be kept a little smaller than the anterior capsulorhexis, and posterior optic capture can also be done for preventing the posterior capsular opacification. So posterior optic capture will be, the optic will be behind the even the posterior capsulorhexis, and the anterior and the haptics will be between the anterior and the posterior capsulorhexis. So the optic will be behind and the haptics will be in between in the bag. So suturing should always be done, especially in children less than 2 years of age. In fact, they say less than 1 year of age, because of low scleral rigidity, increased elasticity, and more vitreous upthrust in children. AC keeps on shallowing. So we need to suture the wounds in order to prevent shallowing and prevent future post-operative anterior synechiae, peripheral anterior synechiae. So it is imperative to suture all wounds with either 10-0 nylon monofilament or 10-0 Vicryl and prevent anterior chamber collapse. For children more than 2 years of age, it can be left sutureless but with proper wound hydration. This decreases the surgical time, avoid suture-related complications like loose sutures and debris collecting on sutures, and decreases need for repeated anesthesia for suture removal, and also decreases the incidence of end-off. So basically under 2 years of age we need to suture, and more than 2 years of age we can leave sutureless provided we have hydrated the wounds properly. Preservative-free moxifloxacin can be given intracamerally, and subconjunctival dexamethasone can be injected to decrease the post-operative inflammation. Follow-up can be done with topical corticosteroids 6 to 8 times per day, tapered over a period of 4 to 6 weeks. Topical antibiotics should be given around 4 times a day. Topical cycloplegics like homide or even tropicamide can be given for 10 days to 2 weeks in uncomplicated cataract surgeries. And follow-up we do with periodic glasses or contact lens in cases of unilateral aphakia, and patching for visual rehabilitation to prevent amblyopia. So this is the last video. With a 15
Thank you, Dr. Parul. We will be taking question after the second talk, that is IOL power calculation. Now I will invite Dr. Savleen Kaur to speak on IOL power calculation. I have one presentation in the next hall, so after one presentation I will come back because due to I think some clash in the program.
We'll just take a minute, so maybe we can take one question if anybody has till the time he sets up for Dr. Parul.
Yeah. No, we do one after the other.
What is the reason that you say that the corneal incision is always a better than the scleral one? Because tattoo is a common weak spot, and we can never assure that the child would not be engaged in violent activities or something other.
Yes, so that is,
And
yeah. No, scleral incision, yeah, it becomes a permanent weak spot, but
the chances for end of it has been shown by many of the papers that it's more in the
corneal incisions. Yeah, so that is surgeon preference. If you feel more comfortable with the corneal incision, because sometimes the surgeons don't feel very comfortable with the scleral incisions. You need to go under the roof. It is like a surgery which you are doing under the roof. So, and the clarity is also more in a corneal incision because you are closer to the field of. That is why we choose a superior incision, because due to the Bell's phenomena and the superior eyelid covering the upper portion of the cornea, the trauma is prevented in a child. So we don't prefer to do a temporal, we do a superior corneal incision.
Good afternoon, everyone. So we're now discussing IOL power calculation, which actually forms the major step when you're planning a pediatric cataract surgery. And I don't think it can be simplified, but we'll just try. So the challenges in IOL power calculation in children are because of major two reasons that you find intraoperative surprises. You have refractive surprises, which can occur early post-operative, or you can see refractive surprises later as the child grows up. So the IOL power calculation can be basically divided into three main things: the axial length keratometry measurement, the IOL power formula that you're using, the target refraction that would be dependent on the myopic shift that you expect that the child would undergo. So the axial length measurement that can be done in office is often very difficult for children because children will not cooperate for a conventional optical biometry that we do in adults. So the error in axial length measurement will also be larger. It's a small eye. It's an eye which is usually shorter when you're doing a surgery less than 20-21 mm. The error will increase from a 2.5 diopter per mm that you see in adult to around 3.75 diopter error per millimeter in a child. You can use the applanation or the immersion scans, whichever is available at the center that you're doing, and the immersion being a little more accurate but difficult to do in children. So the contact applanation scan is the most commonly that we use for axial length measurement in children. The contact technique is also is available more commonly, but also gives more errors. But it's the best that we have. Now, if you do an axial length measurement in a child in the clinic, it will be something like this. The child is squeezing, you are struggling to take an axial length measurement, and there are high chances that it might be erroneous. So if you're following the office measurement axial length, always make sure that you have 2 or 3 readings in one go and try to take the readings at 2 separate visits also. So you'll get a fair idea, okay, what is the average, and if you see a standard deviation more than 2 diopter, repeat the exit length, because multiple readings should have the standard deviation up to say 2 mm. In the OT or the operating room, if you take a measurement under anesthesia, it is obviously more accurate. You can see that the fixation of the child, you can ensure that the eye is stable, it's central, and you're not applanating in the periphery, you're applanating in the center, and you're not actually depressing the cornea. So you can see it reduce your parallax by seeing it from the side, that you're not indenting the cornea too much, just a slight touch on the cornea, and you get a reading. And you try taking another 3 readings and then take an average of the 3. Now, this is corneal compression is obviously more likely because the low cornea and scleral reality. I've played this video to show you, and maybe the sound also is playing to tell you that the oscilloscopes that you see on this, you always have to have an instrument that where you can see the readings of the spikes that are being projected. So you know that you are actually indenting the cornea and you're getting a sound and you're getting a spike, and you can see the spike that is coming from the cornea, and you're getting an accurate or an average exit length. Always know your machine first, because most of these machines are built for adult eyes and they are not calibrated less than 17 mm. So if you are taking an exit length which is say 16 or 17, there are high chances that it will be erroneous, and you might have to shift to a manual mode in your exit length machine. Now coming on to keratometry, now that you have had an exit length and you have taken an average and you have taken reading over 2 visits, keratometry is a problem in children. If the child is old enough, again you can switch to an optical keratometry or a handheld keratometer and you can make the child see, but often not possible. The errors are also up to the range of 0.8 to 1.3 diopter, because obviously the child is not fixing and centering. A handheld keratometer is shown to be fairly accurate and corresponds to the adult values also, and you can take a measurement without the eyelid speculum. I often make the child sleep, make the mother feed the child, and the child is sleeping in the mother's lap, and then take a reading with the handheld keratometer. It's quite accurate. To avoid dryness, if you're taking it under anesthesia, always make sure that the cornea is smooth and it is not dry. When you're taking office measurements, so this is while the child is, just after the child is being fed. So you can see the child is being fed, you can take a reading, then also the child is kind of, dozing off, and you can get a fairly accurate reading. Again, always take an average of 3 readings when you're doing keratometry, with a standard deviation not too high in between the readings that you take. Under anesthesia, it's obviously very, very convenient to take a keratometry reading. You can just focus on the Myers C, that the cornea is clear and not dry, and then you obtain a keratometry reading which is something like this, that the machine reads. Any handheld keratometer that you have, you can use that. If you have the exit length and you have the keratometry, your job is like 99% done. Optical biometry is of course the best. If you have a child say 2.5 or 3, I would say just talk to the child, play with the child, make the child a little comfortable. They will sit at the machine and you can get a reading which is obviously the best of the readings that you have had with the handheld machines. It is claimed to be superior, and it has high reproducibility also, and it's a contact-free measurement and should be your first choice in an older child. Now once you have the exit length and the keratometry in a setting where the child is not cooperating for an optical biometry, we should just go back and just go through and brush up our principles of refraction in all these cases, because this is how we are calculating in the operating room. So we have obtained an exit length as well as the keratometry under anesthesia, and we are feeding it into whatever machine that you're using, even the adult IOL master that you're using. You have fed the the exit length. So this is something like this, and the keratometry which you have obtained under anesthesia or making the child sleep. You always make sure that you choose the A constant of the IOL as in an adult, and be careful of the formula. We'll just discuss it in a later slide also, that what formula we are using. Sometimes you have to switch, as I said, to the manual mode, because the machine, no financial interest of course, this machine is being calibrated for exit lengths more than 17 mm. So the error is expected to be high. So we try taking the readings on a manual mode to make sure that we do not have errors that can happen. You can set the target refraction that you want in a child, which will depend on the age of the child that you are operating at the time of the surgery. So then you can set the target refraction also, and then just have a look at the IOL power that you want to implant. You can obtain an exit length, and then you can just put a value of 43.5, that is the average keratometry, and feed it into an IOL master as well. So you'll get a printout and you can just see how much refractive error will you expect if you have put the present axial length of the child within average keratometry of the adult, and that is the refractive error that you can just calculate what you want to do. Now, which formula to use? So there are a lot of studies. We have been using regression formulas SRK and SRK2 over the years. Now we have theoretical formulas also which are coming up. A lot of studies talk about which ILPAR calculation formula we should use and what age should we implant, and we did publish our own views in the Indian Journal of Ophthalmology. Now, the various studies that mostly talk about holiday SRK2 and SRKT, and these two formulas, I would say these three are the most commonly used. The infant aphakia study has used the holiday and the SRKT, and they found it to be the most reproducible in children. And there's a large paper by Vasavada et al., again SRK2 and holiday 2. But again, you see there is no present consensus because all these formulas are designed for the adult eyes, and we cannot choose one formula for a child. So what you can do is always take the two best available formulas that you have in your ILPAR machine and just try to see how much error each one of the machines is giving. And we mostly use the SRKT and the holiday. These are the two formulas which have the errors also almost close to each other. So but again, these are all adult formulas, so choose the best two formulas that you have and then take an average. Now comes on to the target refraction that we want to choose, I think, which is the most difficult part. So under correction, I think most of the talks we have that basis in mind that we are dealing with a growing eye here, and it is expected to grow into myopia. So when you're anticipating a myopic shift, you have to undercorrect the power that you choose so that the child has an early hyperopia. Now the target power should be balanced so that the hyperopia should not be that much that the child is amblyopic at the time of cataract surgery, and it should not be that low or negative so that it turns into a high myopia later in the life. So how much to undercorrect is again a topic of debate. Always think about the time or at the time of cataract surgery in when you are deciding your ILPAR. Always look at the fellow eye. So if you have a bilateral cataract, you would want a hyperopia of say +7 or +8, and you can plan that for both eyes. But if you have a unilateral cataract and you give the child a hyperopia of +8 and the child is plano in the other eye, there are high chances that that eye will end up into amblyopia. So you can choose a moderate amblyopia for a unilateral cataract and say a equal amount of moderate to high hyperopia for a bilateral cataract. Of course, visual acuity, again, dense amblyopia, you don't want to lead the child into a high hyperopia again. The Dahan's rule is the simplest and the most commonly and the over the time rule that we have been following. You just take the axial length and you decide the ILPAR. Now, when you use this ILPAR, this is for any axial length and any age. So you don't need to undercorrect this ILPAR. This is just the ILPAR that you'll implant. But this will give you a hyperopia of say +7, +8 when you are dealing with an infant. So less than 1 year, less than 2 years are the most commonly used age group where you will not be able to obtain a keratometry and you will implant this ILPAR. So for children between 2 to 8 years, you need to undercorrect to do a biometry and then undercorrect. There's a rule of 7 that is also followed, that this is the age of the child, so you have the ILPAR and this is the target refraction that you can choose. This is based on the concept that at age of 7 years the child will be emetropic. So the newer studies have shown that this age is not exactly 7, it varies somewhere between 4 to 5 years of age. So over the time, people have reduced this age group to say, you aim hyperopia at around 5 to 6 years. That is what the age where you can implant an emetropic PAR, especially when you are dealing with a case of a bilateral cataract. So the residual hyperopia would again be based on these multiple factors, but the initial hyperopia should be low to be corrected by either a contact lens or glasses to facilitate compliance with the amblyopia therapy. It should not be that high that the child does not wear the refractive correction and ends up into amblyopia. So we have been using the SRK2 formula, and we have a lot of publications where we have aimed at around +4 diopters in 1 year. So what we follow is the rule of 5. So by 4 or 5 years, you'll have emetropia, and below that age group, you can target a +4 in a 1-year-old, a +3 in a 2-year-old, a +2 in a 3-year-old. So the total is 5. So this gives you a moderate hyperopia, a mild to moderate hyperopia of say 4 or 5 diopter if you are operating on an infant. say 1 year of age. The infant aphakia treatment study did an 8 diopter undercorrection, so that is quite different from what we follow. Most of the Indian literature would say +5, +6. That is what they found out. That is what that was. Sorry, can I just go on? If you can remove that also, it will be great. Yeah. So the outcome of surgery depends on the time at which you did the surgery, and this is the last thing that I want to show. Myopic shift again has multiple factors, but if you compare the Western literature from the Indian literature, somehow the myopic shift that we have reported is lesser than the West. It could be a genetically predisposed eye. It could be, some genetic predisposition to myopia and glaucoma that we have. But less than 2 years, if you implant an IOL, the myopic shift over 8 years is around 2 diopters. So you can see that up to 8 years, the initial Dahan's rule that said emetropia at 8 years, we can now reduce to say 5 or 6 years and then aim for a emetropia at that age. So the major challenge after a well-done surgery, to summarize, is again the post-operative refractive error. You don't want to do a perfect surgery and then end up having a myopia for sure in children. So you have to have a hyperopia in the first post-operative period when you see when you're talking about a surgery in a child less than 5 years of age. This refractive error depends largely on the power of the IOL and the post-operative target refraction that you choose. And there are a lot of difficulties in taking this measurement. The axial length, keratometry, the formula, all three will corroborate to the refractive error that you see sometimes and will not corroborative to the refractive error that you see sometimes. So it's a mix and match. It's not always the error of the surgeon, it's the error of the calculation and most importantly the error of the measurement that we have done. It is crucial to obtain an accurate IL power by taking some precautions, and you can take precise measurement and do age appropriate calculations so that you diminish this risk. I would like to acknowledge my seniors. Dr. Jagat Ram would join us and I would be happy to take any questions till then. Thank you. Yes. See, if you're yes, so if you are targeting a hyperopia of say +8 or +9, that is the problem. It will be very difficult to make them wear +8 or 9 in one eye and 0 in the other, and then of course giving them a reading ad. So for a unilateral cataract, aim for a +4 or 5 max. Don't go beyond that, because that power is known to be well tolerated. And yes, you can give the bifocal, of course, if you're operating more than say 2.5 years. Below that, just add the near ad, say give a 7 to a child who is operating less than 2 years of age, and you have targeted a +4 refractive error. So +4 and the near ad of 3 will be around +7 for that child. And you have to do patching, needless to say. You have to make them patch, make them understand, make the parents understand that you have to make them patch immediately. As soon as say you get the first reading at around 3 weeks of age, you start patching. So you feel that the tolerance to the bifocals is okay? The tolerance to any power in a kid is okay. So any power, initial was that we used to undercorrect even myopia, hyperopia. The school of thought was that undercorrect the power, they might not be able to tolerate. But if you have a power of +8 or +9, whatever you obtain, give that power. Because you do not want to undercorrect now, because undercorrection would, again lead to a abnormal emetropization. Yes, please. So if I have to go by the textbook, 1 year so 2 years is what the literature says, but we are implanting, as Sir said, after 4 weeks. 4 to 6 weeks we have started implanting IOL, but I will put a disclaimer to that. You have to have an IOL, the axial length more than 17 mm. You have to have the corneal diameter more than 10 mm. If you have some comorbidities, say ROP or say glaucoma, then you can take a reading of the back diameter also and look at the back diameter, that should be more than 10 mm. So these 3 disclaimers, if they're all right, you can implant an IOL in a child who is as less as say 6 weeks of age also. There is no contraindication to that. But yes, if you have if you go by evidence based, the infant aphakia treatment study is the largest randomized controlled trial, and they go against IOL implantation in children less than 2 years. So we have an RCT, we did an RCT at our center, and we did implant IOL at less than 2 years also, and we followed them up to 8 years, and they were doing just fine. The problem is the contact lens compliance in our country. So because they'll never wear the contact lens, if you do not give them an, if you don't implant an IOL, they'll end up being amblyopic. So their visual acuity would be lower than a Western treated child who has a contact lens in place. So the compliance to spectacles in our country is higher than contact lens. So and if you implant an IOL in an eye which is less than 2 years of age, you give them some power and they have some vision. Because if you leave them aphakic less than 2 years, then there are high chances that the child is not using that eye.
But as you said, the kids, they accept whatever power.
Yes, they do.
So
You have to make them wear. That is the problem.
So you mean to say they don't?
So, in aphakic child, you give them a plus 10 or plus 12 diopter glasses. So if they're not
no, this is
using-
below 2 years, I'm telling.
Yes, so below 2 years, we are implanting the IOL. That's what I'm saying. But if you talk about evidence, so we have less evidence for IOLs less than 12, but it is safe if you do your measurements properly and if you keep in mind that it's a well-grown eye for that age, then you can implant an IOL. Thank you.
In cases of unilateral cataract, what is the cutoff age when you prefer multifocal IOL, especially in unilateral cataract?
So Dr. Jagat Ram is doing it at 8 years.
8 years.
So that's what we have been doing. So 7 or 8 years after that, we do give an option if there's no financial constraint of a multifocal IOL.
In comparison to bifocal, when you are giving in unilateral cataract, sir is not implanting multifocal in unilateral.
So it's
cataract.
not a norm in children because there are a lot of other issues also. It's just not the IOL. The IOL power calculation again is an issue. If you think it's an accurate IOL power, then financial problem is an issue because these children mostly are from the lower socioeconomic strata. Then the third most important problem is they're not able to tell the other secondary problems of glare and halos. So we are very, very selective, very, very, very selective for a multifocal IOL. Sometimes the parent has read it somewhere and they know about it and they ask you about it and you do an accurate measurement and you see that you can, there is a chance that the child is able to tell you about the problems and tell you about you have a lot of instruments these days, the eye trace, that will tell you what kind of vision the child is going to have with the multifocal IOL. I think you can go for it. The extended depth of focus IOLs, I think they might be a better option because the intermediate is the one that we want to give it to that child.
Okay, thank you.
Excellent presentation, ma'am. Wanted to ask you one question regarding unilateral periodic cataract IOL implantation. Is as far as amblyopia is concerned, isn't it creating anisometropic myopia beneficial than creating anisometropic hypermetropic?
Yes, for amblyopia, yes. But if you make the child myopic now, and then say 5 years down the line, you see the amount of myopia, anisometropia you will generate with the myopia. So the amount of anisometropia you're generating with the hyperopia is going to decrease, but the amount of anisometropia that you induce with the myopia is going to increase over time.
Ma'am, but still the difference that is there in between the two eyes, it is tolerable in case of myopia more, and
Yes,
the
but
child
we're
will
not
need the
talking
near vision more as compared to the distant one.
Absolutely correct, but you talk about a child who is having a say plus 5 of anisometropia because it's plus in one eye and 0 in the other. 10 years down the line, he's going to become say minus 5. But if you aim for say a minus 5 or a minus 1, the child is going to increase every year. So the anisometropia will increase, the magnitude will increase every year.
By that time he would have the amblyogenic age, right?
By 7 years, that is the most crucial time that you want the child not to have amblyopia.
Okay. Okay.
Yeah, so that is the age that they will develop amblyopia, and then if it is myopia or hyperopia after that, the battle is gone. So because we've crossed that age.
Okay. Thank you.
Vitrectomy in those cases less than 2 years, whether
Yes. Even if you do if a well done PPC and anterior vitrectomy, the chances are that 20% cases you'll still have a PCO.
You have done so many cases, no? I mean,
So
less
yes,
than
I'm
2 years.
reporting the results at our center. We put together all the surgeries that all of us had done, and it came out to be 17%.
17%.
So this can be not only due to surgeon factor, it could be just a cortical cleanup, you know,
Okay.
that Dr. Parul stressed. So after you've done the PPC, you have done an anterior vitrectomy, the anterior capsule has to be polished. So that also leads to proliferation. There are some eyes which are predisposed to. We try to do a laboratory study, checking the cytokine levels in these eyes. So the eyes who are more prone to develop PCO have a raised cytokine levels to begin with. So there are some patient factors also. And of course, that is what I think should be the area of research in pediatric cataract.
Thank you.
So bang on time. So thank you very much.
So I invite our esteemed previous head of department and previous director PGI for a talk on surgical tips and tricks for complicated pediatric cataract surgeries. Professor Jagat Ram.
At present, I am not director PGI because I have completed my tenure. I completed 42-year, 6-month service at PGI, and my tenure is over. So I am in the Grewala Institute at present. So I missed their talk because my talk was in the other hall. वीडियो है चलो इसमें ऑडियो नहीं होगा आप ऑन कर दो इसको नहीं इट इज नॉट कमिंग देयर नोट नाउ आप इसमें वो देख लो ना इसमें नीचे यहाँ देख लो क्या है What is happening? इसको ठीक कर दो ना ये है हाँ ये है दिस इज आप अपना वो ठीक कर दो ना वीडियो विल रन बट आपका वो कनेक्ट कर दो ना इसको it did not work, but I hope now it work. I will be showing many of the complex pediatric cases. What we have to do, we have to diagnose, plan, innovate, execute, and follow up these patients. This is one patient where it is a zonular cataract. First I will like to show a simple case. For the beginner, we will always like to stain the anterior capsule for the beginner, and make about 5 millimeter continuous curvilinear capsulorhexis, and then remove the cortex from the capsular bag after multi-quadrant hydrodissection. Once the cortex is removed, then we fill the capsular bag with viscoelastic and make posterior continuous curvilinear capsulorhexis, initially with the needle cystitome, and then subsequently we complete it with the utrata forceps. Size of the posterior rhexis is kept around 3.5 millimeter. So this is time salon for removal of any vitreous tag, but then all the cases we use hydrophobic acrylic IOL, whether it is a 3-piece IOL or whether it is a single piece. Most of the time we use single piece IOL. It is very easy to pass it into capsular bag. Now I will like to show the complicated cases. They include PHPV, ophthalmos, uveitic patient, coloboma patient, and some of the other complicated cases. Even posterior lenticonus is found to be very you have to diagnose it before surgery. This is one such patient of posterior lenticonus, which we dilate each of the eye of the child and then plan the surgery. This is completion of the rhexis. This is followed by limited hydrodissection. Actually, if you do much more vigorous hydrodissection, it will rupture. So you have to do very limited hydrodissection. I am not putting any pressure on the posterior capsule. It is a pre-existing posterior capsular tear in lenticonus. So here hydrophobic acrylic IOL. This is implanted into capsular bag, and any of the vitreous is removed, and you can more importantly find out the tag, that there may be vitreous tag. So this is the final picture here, and this is after 8 months there is a posterior capsular opacification. This is anterior segment OCT, and this locate the IOL position. This is another child where there is a juvenile idiopathic arthritis and uveitis, and there is a cataract. Pupil is very small, and in such patient we use Malaysian ring. Stretching will lead to more tears, so Malaysian ring is ideal for such cases. This will give adequate dilatation of the pupil, and here rhexis is done, and then removal of the cortex and removal of the lens epithelial cells. You can put either of the IOL, whether single piece or 3 piece. In such patient in chronic uveitis, we like to do peripheral iodectomy, which is not routine in pediatric cataract surgery. This is one child with 4-year-old child with congenital lenticular coloboma with astigmatism. So here issue is stabilization of the capsular bag. There were posterior synechiae, so those synechiae were released, and rhexis is completed. Then actually what we have to do, we have to use hooks. These should be Capsulorhexis hooks. There are iris hooks also. Many a time we use that also, but their edge is are not smooth, so they may lead to tears of the rhexis margins. Here we are using Sioni ring. This is a single eyelet Sioni ring, but if it is much more subluxation, you have to use two eyelet Sioni ring, or you may use two Ahmed segment. So we have used Callisto in this child, and implantation of IOL into bag. So we achieved very nice fixation. For closure you can use glue, and this is the final picture before and after the anterior segment OCT. This is a child small clip, 4-month-old child with the double crystalline lens. We have a completed follow-up of this child now more than 9 years at present. Child is now more than 9 years, and here two rhexis were done on each of the lobe of the crystalline lens, and we customized the IOL. IOL was you can see 18mm IOL, which many companies they will fail, particularly those foreign companies, they will fail to. But here we have implanted IOL in the bag, and this child we did occlusion therapy. Child can see through this eye by capturing even the smallest object. Then most important issue is persistent fetal vasculature. This is very, very common. So each child you have to dilate and see, but this was a little unusual because this is a hemorrhagic type of persistent fetal vasculature. You must have cautery with you, and cauterization of the this posterior capsule has to be done, so that there is no bleed. And sometime even that you have to cauterize the stalk so that there is no bleed once you cut it. And then vitrectomy in the zone of posterior rhexis, and then this is the implantation of IOL into the actually it was captured here because it was placed in the sulcus and captured because posterior capsulotomy was large. This was just to stop any bleeding in the which may not occur in the post-operative period. Although we have done nice cauterization, these were some of the other children where we have done PHPV with the IOL implantation. So this is so in conclusion, favorable outcome can be achieved in these complicated cases. We have to plan and meticulously perform the surgery. Thank you very much. So this was just a 10-minute video. I made it because there are so many complicated cases, but I thought that I should show simple case and few of the complicated cases.
Thank you, sir, for excellent surgeries. Now I invite Dr. Sableen to present Dr. Jaspreet's talk, Intraocular Lens Implantation in Children, When and Where to Place.
Yeah.
As usual, excellent presentation, sir. In cases of PHTV, the role of radiologist is immense. So, as they do color Doppler and diagnose vascularity. So, in pre-operative period, it is very helpful whether a stalk is vascular or non-vascular. So, one can take precaution accordingly.
I think that is a futuristic idea because usually these children, they are detected to have this PHPV post-operatively, because this persistent fetal vasculature, it closes almost within a month period. In the first month after birth, almost 97 to 98%. So whatever other cases are there, for curiosity or for that, I think, but intra-uterine we have not done any.
Okay, sir. In last one case, I have operated 1 month back. I have sent that patient for color Doppler, and they have reported that a stalk is non-vascular. And during surgery, it was found that it was just atrophic stalk. The vascularity was not there. So it can be confirmed.
Yeah, definitely. I think that will be helpful. If it is done, that will add another. This will be definitely nice.
Thank you, sir.
Thank you so much. I think if there will be time, so we will take up the more questions and. The topic which was for Dr. Jaspreet Sukhija, intraocular lens implantation in children, when and where to place. Dr. Savleen is presenting because Dr. Jaspreet could not come because he was hospitalized.
Thank you, sir. So after those wonderful videos, we'll just describe one or two different sites of intraocular lens implantation that we can keep in mind when we are dealing with such complex cases. So we have discussed that the indications of intraocular lens implantation are axial length more than 17 mm, a corneal diameter more than 10, in age more than 6 months, as given by the infant aphakia treatment study. There is no consensus on younger children, and of course we do keep into consideration the fact that we are dealing with a completely demographically different population than the West. So the intraocular lens implantation by convention is endocapsular, that is in the bag implantation, and the other techniques that we can do in certain difficult scenarios that we come across could be an optic capture, which can be done anteriorly, that is the bag is the IOL is in the bag and the haptics in the sulcus, or it can be done posteriorly, that is the optic is behind the posterior capsulotomy. We can choose the sulcus implantation in selected cases, and of course Mary Hoyt-Exignan has described the bag in the lens technique that can also be done. So a routine pediatric cataract surgery, we have seen the steps, that is it includes a complete lens aspiration after a good anterior capsulorhexis, a primary posterior capsulotomy, anterior vitrectomy, and an intraocular lens implantation in the bag. So once you have fashioned an anterior capsulorhexis, you do a irrigation aspiration of the cortex, then you implant the IOL after inflating the bag with a viscoelastic. So you can do a posterior capsulorhexis either before intraocular lens implantation or after intraocular lens implantation. Manual posterior continuous curvilinear capsulorhexis before intraocular lens implantation is the preferred and the better technique if you have the expertise to do that. Here we are using triamcinolone to stain the vitreous and then do a limited anterior vitrectomy. After you have done the anterior vitrectomy, you see that the margins of the posterior capsulorhexis are no longer rolled. That will tell you that the adequate vitrectomy has been done. And then again you fill the bag with a high viscosity viscoelastic substance, and you implant the IOL, the optic and the haptic both going between the margins of the anterior and the posterior capsulorhexis. That is the endocapsular or the in the bag implantation of the IOL. As we discussed that even after doing a good surgery, including a anterior posterior capsulorhexis and an anterior vitrectomy with an in the bag intraocular lens implantation, you do see a 17 to 20% chance of posterior capsular opacification also. So the there has been a lot of no consensus on actually whether you can do a posterior optic capture without vitrectomy to implant the IOL. We did publish a paper in the Indian Journal of Ophthalmology. So this is a posterior optic capture. In this, you'll implant the IOL behind the posterior capsulorhexis. The idea is that you do not do an anterior vitrectomy. You just push the vitreous back and you put the IOL in the Burgess space. That is the more physiological space for the intraocular lens. So I would just skip the few steps because we have already seen that you have dilated the pupil by an intracameral So you have dilated the pupil intracamerally by using phenocane. Sorry. Somewhere here. So, and you have done, somehow the video is not playing. Is it? Okay. So you have done an irrigation aspiration, and then you inflate the bag by the ophthalmic viscosurgical device. You fashion a posterior capsulotomy in the same way that you did when you were planning an in the bag intraocular lens. Should I wait?
There is still time. There is still time for completion of the session. This is the last presentation.
I can just switch to the video. Okay, I'll just play the video from here. ये presentation चला दूँ दोबारा? Okay, wait. I just have to forward it. Okay, so you have fashioned a posterior capsulorhexis, and now you'll implant the IOL. You have a prefixed, preloaded IOL or a 3-piece IOL, whatever IOL you do, you implant the optic in the bag and then you dial it completely. After you have implanted it, you push the optics of the IOL behind the posterior capsulorhexis or capsulotomy that you have made. So you see you've pushed one haptic and the other, and you see this elliptical shaped posterior capsulorhexis because of the optic that is behind the capsule. So the optic is pushed back, the haptics are in the bag, and this is a posterior button holding or posterior optic capture of the IOL. So you're not doing a vitrectomy here because there are certain proponents of vitrectomy, and there are people who say that vitrectomy in a growing eye can have negative effects including retinal complications. So by this technique you avoid doing a vitrectomy and you are still obtaining a clear visual axis. The paper that I was citing, we compared intraocular lens implantation in the bag in one eye and posterior optic capture in the same patient in the other eye. So you are doing away with the patient factors, and we saw that you do have some lens epithelial cell proliferation that you see in the bag IOLs, but a posterior optic capture gave a clearer axis. Of course, the rates were comparable. So it's not a superior, but it's an equivalent technique to an endocapsular implantation of IOL. There are scenarios where you would want to do an anterior optic capture also, like the one that I'm showing. Again, we published this cataract surgery in children with buophthalmos, a series of patients where you have implanted the IOL anteriorly and captured it anteriorly. So this is a buophthalmic eye, again fraught with certain complications. You're doing an anterior capsulorhexis. Now, if you implant intraocular lens in the bag in these eye, the IOL tends to wander because it's a bigger eye and you're putting a normal sized intraocular lens. So either you have to fix this IOL somehow. So you are fixing it anteriorly. So you again dial it in the bag, and then the optic is captured in the anterior capsulorhexis. So this is anteriorly captured. So the IOL is relatively stable. This elliptical margin that you're seeing is now the anterior capsule. So to conclude, primary intraocular lens implantation is a good option when you are doing a pediatric cataract surgery, and it's a clean cut case. And primary intraocular lens implantation is of course avoided in certain cases, but when you are choosing for an intraocular lens implantation, conventional placement is in the bag, can have certain issues of visual axis opacification and glaucoma. So you can refine your technique by choosing an anterior and posterior optic capture, of course with the adequate surgical expertise. The interior optic capture is a good technique for buophthalmic eyes, and bag in the lens is also a promising technique if we have that in, because of its limited availability in India. Thank you.
Thank you, Dr. Savleen. Now we can take up any questions because we still have 8 minutes, I think 8 to 9 minutes are there. Any question regarding the technique? Because what Dr. Savleen described is that we either implant IOL into capsular bag or we do the capture. Capture is of two type. One is when you place the haptic in the sulcus and optic in the capsular bag. That is one type of capture. Another is the last video clip which she showed is that IOL is placed in the bag and optic was pushed into the vitreous cavity. That is the posterior capture.
Regarding posterior optic capture, although it is emerging concept, so what is the case age? What are the cases in which you would like to
No,
prefer
it
to
is,
go
I
for
think,
posterior optic
technically
capture?
there is no such this, but technically it is much a little more technically difficult. But once it is done, we are doing study where in one case you do implant IOL in the capsular bag.
Yes, sir.
That is shown on the left side, the slide, one of the slide, and in the other, it was posterior optic capture.
What is the size of posterior capsulorhexis in these cases?
I think it has to be minimum
Similar or
4 millimeter.
similar or
larger,
larger
a little
than that?
larger than.
It has to be larger than the normal normal posterior axis. Usually posterior axis we keep 3.5 or so.
Okay.
Approximately. So here it has to be more so that IL optic can go into the
Go behind.
vitreous cavity.
Behind the,
The
posterior
posterior
capsule. Thank you, sir.
Sir, what are the parameters for the refractive?
Parameter is what we have to do while we are doing anterior vitrectomy. One is in our machine cut IA or IA cut. Initially we do cut IA. Cut means that it will cut the vitreous and then aspirate if you press more. There is another mode in the vitrectomy machine, that is IA cut. IA cut means while you have implanted the IOL and you want to remove the viscoelastic and you want to remove the vitreous, that is the IA cut mode, means it will aspirate. In the cut mode it will cut more and aspirate less.
So what should be the cutting rate and the aspiration rate?
It should be if it is a thick posterior capsule or otherwise PHPV, for them you try to reduce the cut rate. You say maybe 400 or so cut, or if you do more and more, say 1000, it will not cut. That is roughly I am saying that cut rate is reduced in a thick posterior capsule or such as vascularized cauterized posterior capsule.
And sir, in some of the cases what I have found is that there is a plaque over the posterior capsule and that plaque can be removed just like a Rexis with a 26 gauge needle also. So what are these cases actually, and so what is the also further prognosis for these patients, because I've done a couple of cases like
No, this is very nice, this observation. We also have found that posterior capsule there may be just avascular sheet. It may not be PHPV, it may be avascular sheet. So with the 26 gauge needle you try to lift it, or with Rexis forceps you try to lift it and take out with Utrata forceps. And then you may do primary posterior capsulotomy even. In some cases if child is in the first 6 years of life.
So what is the origin for these cases? Have any you have done any studies regarding these cases? So what are these actually?
So etiology.
Exactly, I think they may be those many of the patient where there is regression of the PHPV that vascularized, and many of them we have found vascularization also, that is occluded vessels, but many of them are just like plaque.
A specific genetic mutation also sometimes causes a peculiar kind of morphology of the cataract that you see, and posterior capsular opacity or posterior capsular plaque is also prescribed in a genetically predisposed population.
So the PAX6 mutations
Yeah.
will lead to a anterior type
On-
of a cataract. PAX6 mutations will lead to an anterior type of cataract, and PIX T3 will lead to a posterior type of a.
Your view on claw IOL, sir, and if bag is not sufficient and not able to put the IOL, PC IOL, then claw IOL can be used.
And iris claw.
Claw, I have not used iris claw lens. So I can't answer because I have not used iris claw. I have used maybe initially one in the sulcus. I have used, if it has to be in the sulcus, it has to be 3-piece IOL or in the bag. Professor Khokhar will like to answer because I don't know, I don't have experience of iris claw lens, so I can't answer.
You talk about the iris claw lenses, right? See, iris claw lenses, when they started, it was put by the Semina et al. Group, and they used 14 patients for 13 years. They followed up. They did in the anterior front of the iris. And in their study in unilateral cataract, they didn't find any extra dropping of the endothelium. So I don't know, I take the study with a pinch of salt, although they had a 14 years follow-up for 13 patients, which is a long follow-up. So for the last 4-5 years at the RP Center, we started doing retro-iris fixation.
Yeah.
So because my cornea colleagues are very unhappy if I put in the front. See, the iris is a dynamic structure. You step out in the sun, the pupil constricts, you come in, it dilates, it's moving, it's a dynamic. So you want to fix something to that, you ensure that it doesn't hit the endothelium, which is the anterior, the lens moves a bit. So we started doing retrofixation now, and we are very happy with that. We finished about 55 eyes, and all of them were good. Only one got dislodged, and that was because the patient got hurt in the eye. And these patients we took were patients who were 6 years and above. And there was a subluxation patient. So these subluxation patients as such have corneas which are thinner. So the SFIOs in the Beals cases, Marfan's homocysteine, all these patients is a big no because the endothelium, the sclera is thin. So the haptic is going to actually extrude out or go in backwards. So one should not do SFIOs if the corneal thickness is poor. The scleral thickness is poor. So I think iris claw is the next big thing which is going to happen. And all these Yamane and all those are not as good because Yamane actually holds the lens at 2 places, 2 points only, and the lens moves. So if the sclera is thick, do a scleral with a pinch of salt, more than 10 years. But otherwise, iris claw, I think, sir, is one of the good lenses. And we got 3 years follow-up, and all the patients are doing fine, actually.
Thank you, Dr. Khokhar. Actually, we will be completing our instruction course. Time is almost over. We will answer any of the question of any of the person, even outside.
No, please continue, because I don't think my people have come yet. So, what is it? Oh, they all are here.
Now, because actually by they are the people, they will tell us that we have to complete. So,
2 minutes, you can answer whatever they want.
any more question? I think
I would
any.
just like to, sorry to interrupt, I just incomplete his question that he said. I completely agree with what Dr. Khokhar said. But if you're asking for a normal pediatric cataract, I mean, I have just 10 or 15 cases, sir, of retrofixated that I did, but only in ectopia. Not in a
ectopia.
normal case of pediatric cataract that we were discussing.
Yeah, but if you don't have a support of the capsule, of course, that's what they're talking
and
about. Yeah.
trauma or in ectopia, maybe retrofixated is a very good.
If your aggressive friend outside has done a good lensectomy, when they say good lensectomy, I always tell these guys to, for God's sake, leave some rim in the periphery so you can go later on and put a physiological position
second
lens.
rim.
But my surgeons, retinal guys outside, are very aggressive. They'll make sure each and every millimeter of the capsule is taken away, and then you're stuck without anything. So I think iris claw is a big way to go.
Have you implanted it immediately or later in the ectopial lentis cases? Because
Immediately, on the table,
No,
please.
we have also done few cases, whether you did it as a secondary procedure.
All the patients were on the table.
Okay.
And we got this idea because we picked up some cases earlier as a pilot study in which the patients were done outside. Then we realized we could do it. And
We do it routinely in adult cataracts,
yes.
but
No, in
we
pediatric
are
also, yeah.
for few cases we have also
5
done.
years, 6 and above, because the IL power has become stable now.
Okay.
Because if you do for the younger ones, it's not good. As such, the subluxation patients, they'll come to you only at the age of 5 years.
5 years.
95% patients, because when they step out of the house, go to the college, school, that's the time when they can't see the distance because they become myope. These lenses are globular because of the myopia, and they have astigmatism. In the house, they can work around because the distance is small. So moment they go to college, 5-6 years, they come to you, and you can do a primary implant right away.
Sir, do you use Sione ring? We have done around 14 cases of with Sione ring in
Sione, you have to fix it to the sclera. So I've done few patients. I did one in Australia actually, the same patient with a spherophakia.
Okay.
But the problem with those ones is you have to follow them and you have to give an instruction not to cut these sutures, and the sclera has to be thick. If you have a swept source OCT, you can measure the thickness of sclera.
Okay.
1.5, it's good, go ahead. If it's less than 1, please don't do these patients.
Thank you very much. Thank you so much. I am thankful to all of you, and I am thankful to my co-instructor, Dr. Parul Chawla Gupta and Dr. Savleen Kaur. And most importantly, our audience. Thank you so much. And thanks to Dr.
Yes, sir, always.
Kokhar also.
We learned so much from you, sir.